Thank you for joining us this evening. My name is Julian Capelli, and I'm the chair of the Education Awareness Committee here at Lupus Ontario, and will be your host tonight. Lupus Ontario is the largest provincial voluntary organization dedicated to improving the lives of people living with lupus. Our mission is to provide vital support, education, awareness, advocacy, and research through the fundraising efforts of our staff and volunteer community to help those with lupus live longer, healthier, and better lives. I'd like to welcome everyone to tonight's webinar, where we'll be exploring research on patient perspectives on mental health and cognitive dysfunction SLE, based on original research conducted in this area. This session will highlight the lived experiences of individuals with SLE, shedding light on the emotional and cognitive challenges patients face and their clinical implications. Insights from this work aim to inform more patient-centered approaches in both clinical care and future research. And a very special welcome to our guest, Dr. Justin Smith, who will be presenting tonight. He is an adult rheumatologist now practicing out of the University of Alberta in Edmonton. He recently completed his fellowship in SLE at the Toronto Western Hospital under Dr. Zahi Touma and was the Geoff Carr Fellowship recipient during the 2024-2025 cycle. He completed his undergraduate degree at the University of Calgary and his medical school internal medicine and adult rheumatology training at the University of Alberta. His goal is to continue to use research to bridge the gap between patient experiences and clinical practice. So without further ado, I'd like to hand it over to you, Dr. Justin Smith. Thank you.
Thank you, Julian, for the introduction. I'll just get my slides going here. All right, so hopefully everybody can see those. So like already mentioned, my talk is titled Understanding Patient Experiences, Mental Health and Cognitive Challenges in Systemic Lupus Erythematosus, or SLE. My name is Justin Smith. I'm a rheumatologist in Edmonton, as was mentioned. I just finished all of my training recently, and so I'm just getting my practice up and running as well as my research career. So I'm super happy to be here to present some of what I've been doing over the last couple of years. So without further ado, I don't have any financial disclosures relevant to this talk. Regarding the research, I will talk about some of my original research as well as highlighting some existing literature. I do talk about a patient case, but no real patient information is used, and I won't give any individual medical advice, but I will be talking a little bit about management. And then other than that, this is a safe and supportive space, so questions are welcomed. And due to the nature of the topic, I know that it can be an emotional topic. So if there are any, questions or concerns, then I'm happy to address those. So just briefly, the agenda for today. So we'll do a quick welcome and introduction. I will go over a patient case about a patient named Sarah, again, not real. We'll talk very briefly about type 2 SLE symptoms, and then we'll focus on some research in mental health, cognition, and then we'll talk a little bit about strategies and supports in these areas. Okay. So first, I'll just do a land acknowledgement. I'm currently in Edmonton at the University of Alberta. So I acknowledge that we are situated on Treaty 6 territory, traditional lands of the First Nations and Métis people. Very briefly about me, just so you can know who you're listening to. Like I said, I'm a rheumatologist in Edmonton. I just finished my training in Toronto and had the Geoff Carr Fellowship last year. As mentioned, I'm passionate about using research to improve patient care directly. And so hopefully, and in the past and going forward, I hope to continue doing epidemiologic studies, working on clinical trials here in Edmonton, and then also doing some quality improvement initiatives to improve care, specifically in mental health in the clinic space. Personally, I like weightlifting, I do yoga, I like hiking and running. I'm a former gymnast and I was a gymnastics coach for 8 years, so that's something fun. And then I have 3 pets. I have Fitz, the orange cat, Olivia, the black cat, and Tulip, my chihuahua. So first, I just wanted to go over a brief patient case. So this patient is Sarah. She's a 32-year-old. She's a mother of a 2-year-old daughter. She's a graphic designer, and she was diagnosed with lupus 8 years ago, initially having a malar rash, arthritis, alopecia, and low platelets. Currently, she's on hydroxychloroquine or Plaquenil, azathioprine or Imuran, and vitamin D. She has been off prednisone now for 5 years. She recently saw her rheumatologist, and all of her lab work and urine tests came back normal. And according to her rheumatologist, her lupus appears to be in both clinical and serologic remission. However, she has been struggling with a few symptoms. So she's been having brain fog, and she says, I feel like I can't think straight and I lose my train of thought so easily. She's been having memory issues, saying, I am always losing my keys and misplace my phone. She feels fatigued. She's feeling down and isolated at times. And then she's also having increased anxiety about work, personal relationships, and about caring for her young daughter. So she spoke to her family doctor about these feelings. And the family doctor redirected Sarah back to her rheumatologist, asking if these symptoms could possibly be related to active lupus. And her question at this time is, why do I have these symptoms? So we're going to briefly talk about type 2 SLE. And this really is a new paradigm to understand the symptoms of lupus. Um, we've known about these types of symptoms for a long time, but there was a paper recently published in the last few years kind of separating the idea of having type 1 versus type 2 lupus. So type 1 lupus are the type of symptoms that we think of as inflammatory that can lead to organ injury and dysfunction. We can measure a clear-cut relationship with immune system abnormalities. And examples of this would be something like nephritis or kidney inflammation, arthritis, and rashes. So things we can measure and see. Now, type 2 lupus, I often think of as invisible symptoms. So things like fatigue, depression, widespread pain where there is no arthritis, and cognitive disturbances. And these tend to be chronic and they may wax and wane and often unrelated to the actual lupus type 1 activity. And when we give immune medications like prednisone or other immunosuppressants, these symptoms likely won't respond to those. And why are these symptoms important? Well, when we use things called patient-reported outcomes or PROs, these types of symptoms are highly represented and often increase these type of measures because of their prevalence. The problem, though, is that they're difficult to measure, and it's difficult to directly attribute them to lupus. And because of this, these types of symptoms are really not well addressed in clinical encounters, as many patients probably are aware of, and then also research. There's also a discordance in the communication between the rheumatologist and the patient. And I've seen this both personally, and that's represented in the literature. As physicians, we often are looking at objective, measurable things that we can hang our hats on. Things like the physical examination, abnormal lab tests, or imaging studies. Patients, I find, obviously are going to acknowledge those findings, but they also have symptoms that are subjective. And it's difficult sometimes for the physician who's not feeling them to understand. And so we know that that has a personal impact on the quality of life. And so oftentimes I find there's a disconnect between what is leading to what. Now, the problem is these symptoms can result from many factors and are also present in the general population, including in patients that don't have lupus. However, there's a higher frequency of these types of symptoms in patients with lupus. So overall, currently the link there, or the attribution to whether this is directly from lupus or not, is not well understood. So jumping off of that, I wanted to start talking briefly about mental health in lupus. So we know that mood disorders are quite prevalent in lupus, ranging anywhere from 12 to 60%, and that depends on how the study is done or how it's measured. And that's much higher than the general Canadian population, where 5.2% of the population may have anxiety and 7.6% has depression. risk factors that are reported in the current literature for having mood disorders in patients with lupus include low socioeconomic status, longer disease duration, higher disease activity, as well as a lack of perceived social supports. And we know that poor mental health, whether it's in lupus or not, negatively impacts self-care agency, medication adherence, the socioeconomic status itself, and also the overall quality of life. And so I often face this question, and I think about this myself when I see patients, is are symptoms of depression and anxiety actually part of neuropsychiatric lupus, or are they separate? And so there are a couple of models that aim to address this question. There's the biological model and the psychosocial model. So the biological model looks at depression and anxiety as part of the pathophysiology, or that they're actually caused by lupus itself. And we think that there may be an interplay here because these symptoms may actually correlate with systemic disease activity, so active lupus symptoms. We know that there are pro-inflammatory cytokines or immune proteins that can be found in patients with mood disorders, in both patients with lupus and without lupus. We also know that autoantibodies can cross the blood-brain barrier. And if we do advanced brain imaging studies, often these types of studies are done more in research, there actually may be small changes in patients that have depression and anxiety, both in lupus and without lupus. Now, on the flip side, there's also the psychosocial model, in which we know that lupus is a chronic, unpredictable, and oftentimes stigmatizing illness, and that can weigh quite heavily on emotional symptoms and possibly, and probably does, lead to symptoms of anxiety, depression, and other symptoms. We know that there's a higher prevalence of disability, fatigue, pain, and that can contribute to emotional distress. And again, depression and anxiety are common in the general population. So it can't just be that there's active lupus leading to these symptoms. And furthermore, it's complicated because currently in the definition of neuropsychiatric lupus, there are 19 syndromes. That's not depicted here, but 2 of those are depression and anxiety. But when we look at this classification criteria, so these are the classification criteria we use to enroll patients in studies. To say that someone has neuropsychiatric lupus, we're often looking at different symptoms. So things like delirium or confusion, psychosis, or seizures, and that's on the left in the ACR-EULAR criteria. And then in the SLIC criteria, which is just a different type, it's also looking at things like seizures, psychosis, and other things that we can directly attribute to inflammation. So the way that I think about it is that there's probably more of an integrated biopsychosocial model. So the biological, the psychological, and also the social determinants will affect whether or not someone has depression and anxiety. So things like genetics, inflammation, antibodies in the neurologic system, and hormones can affect patients and may predispose some patients more than others to depression and anxiety. And these vulnerabilities, so a person's aptitude to develop these symptoms, can be further exacerbated by other psychosocial stressors. So stigma of illness, financial burden, and life disruption from the disease itself. And furthermore, cognitive dysfunction and fatigue may actually bridge the biological and psychological domains, and then that contributes to both depression and anxiety. And looking at this model, this allows for individual variability. So some patients have more inflammation-driven symptoms, while others have more reactive, to their environment and psychosocial stressors, or it can be a combination of both. And so it's so complicated in lupus, and that's why we are still doing research in this area. And so when I was a resident still in rheumatology, I started this project while I was in Edmonton with Dr. Stephanie Keeling, who's a lupus specialist here at the University of Alberta. And our question was, how do patients and rheumatologists in Canada currently deal with mental health concerns of patients? And so some of you might have filled out this study. It was a cross-Canada study. What we aimed to do was look at the current practices of rheumatologists regarding mental health care for patients with lupus. We wanted to identify the barriers to accessing mental health care among patients with lupus as well as their physicians, and then also to evaluate possible interventions to improve mental health care throughout. And so I'm just going to move my little icon here because I can't see what I'm talking about. So first, just looking at rheumatologist practices currently for mental health care. So we had 25 rheumatologists across Canada. We had rheumatologists from BC, Alberta, Ontario, Quebec, and Nova Scotia, so truly across the country. And we asked a whole bunch of questions, and I'll present some of the more interesting findings here. We asked how many rheumatologists had performed screening in their clinic for anxiety and depression. And you can see here that only 28% said yes, and the rest said no. And then when asked about screening for cognitive impairment, there was a little bit more that said yes, but 40%, so less than half still had performed screening for cognitive impairment. When we asked current practices of rheumatologists for mental health care and concerns, you can see here on the right is the comfortability of either referring to mental health services, asking a patient about mental health concerns, screening for depression and anxiety, or prescribing medications. And you can see that physicians are more comfortable referring to mental health services, asking patients about mental health concerns. But when we're looking at screening for anxiety and depression, and then furthermore prescribing medications for depression and anxiety, rheumatologists are much less comfortable. And then when we looked at the rheumatologist perspectives on possible interventions, you can see here with the yellow arrows, I know it's a busy slide, but they felt that the most feasible interventions would be increased access to urgent psychology or psychiatry support, or access to a referral system for timely services. On the flip side, we also looked at patient perspectives on mental health, and a total of 235 patients with lupus completed the survey across Canada, just to get a sense of the types of symptoms patients were experiencing. So about 41%, or 40% really across the board, reported anxiety, depression, and symptoms of brain fog. And then we asked some further perspectives on mental health. So we asked if the patient had ever had their GP or their family doctor perform screening for anxiety or depression, and 47% said yes, that their GP had performed screening, so about 50%. But when asked about whether the rheumatologist had performed screening for anxiety and depression, it was much less, only about a quarter. So 27% had had their rheumatologist perform standardized screening. And we wanted to look at what prior treatments or interventions had patients been exposed to or experienced. So about 50% had been treated by a therapist or a counselor. Only 17% had actually seen a psychiatrist. And over half had been prescribed medications for either anxiety, depression, sleep, or other mental health issues. So, I mean, these aren't bad numbers. I'm not saying that everybody needs to be treated by a psychiatrist, but you can see that, half of people have at least had some sort of exposure to mental health care. And then we asked, do you think you are comfortable or are you able to get help for your mental health concerns? 18% of patients said they didn't have concerns, so that's great. And 50%, you can see there, 53% said yes, but still there's 29% that said no, they're unable to get help for their mental health concerns. And when you think about the amount of patients that would be across the country, that's likely a significant amount. And when asked about the top reported barriers, we gave a long list of different barriers that affect access to mental health care. The top barriers were long wait times for referrals, issues with affordability or insurance, and I'm sure that that's really directly looking at, um, counseling and therapy because that can be expensive. Um, Interestingly, the stigma associated with mental health was still a top reported barrier, and also lack of time during appointments, which from my side, I also totally understand that. And then interestingly, we asked about possible interventions, and we posed the same list of interventions from the rheumatologist survey for the patient survey. And you can see across the board on the right part of the graph that um, a lot of patients strongly agreed or agreed with most of the interventions. Um, Interestingly, and we'll look at this later, the highest intervention that had strongly agree was integrated services into the rheumatology clinic. And so when we looked at what the rheumatologist had answered and what patients had answered, we were able to analyze the level of agreement through some statistical analysis. And the highest agreement between the two groups was having standardized screening in the primary care physician clinic or the family doctor clinic, as well as having an available referral source for mental health services. And then interestingly, the lowest level of agreement was having standardized screening in the rheumatology clinic and mental health services integrated into the rheumatology clinic. So that's interesting because there's this potential disconnect now between patients and their rheumatologists regarding the expectations surrounding mental health care and screening. Patients, at least from this survey, are saying that they would like to show up to their rheumatologist office where they're getting the majority of their care for lupus, obviously, and sometimes other health care as well. And they're hoping to have their mental health addressed. Whereas physicians, probably because of lack of comfortability or time, did not agree with this, at least statistically. So some sobering thoughts. Patients with lupus in the literature, time and time again, do tend to identify rheumatologists as the preferred access point for mental health screening and care. But in our study, only 4% of rheumatologists actually cited having access to a psychologist or counselor in their clinic, and 28% to a psychiatrist. So quite low numbers. And we know, and I know this just from practice, that we currently depend on the primary care physician for mental health screening and care. Now, the problem with that is over 6 million Canadians lack a family physician. And so at this point, rheumatologists and patients are unable to rely and fully depend on primary care to provide mental health care and screening. So there are some ongoing questions that we have from this study and then also just clinically and with research going forward. So one, are depression and anxiety in lupus part of neuropsychiatric SLE? Or are these distinct comorbidities that are just common in lupus, or is it a combination? One thing that has been studied a bit in the past, but the problem is we don't include patients with true neuropsychiatric lupus in clinical trials, is do biologics or immunosuppressants actually improve mood? There are some studies that say, yes, depression, anxiety, those types of type 2 symptoms can improve with treatment of lupus, but I don't think we know at this point whether that's actually through modulation of the immune system or if that's improving disease activity and therefore other things in the patient's lives improve. The other thing is, how do we disentangle all these other symptoms, fatigue, cognitive dysfunction, and mental health in research and also in practice, because they're so heavily intertwined. And then lastly, which is a big area for future research is the development of biomarkers and more advanced imaging to develop whether or not symptoms are being derived directly from inflammation or whether these are mood symptoms that are reactive to the surroundings. So that was a very brief overview on the research I did on mental health. But I wanted to shift focus now to cognition and cognitive impairment in lupus. So cognitive impairment in lupus, we often call it lupus fog or brain fog. But what is it? So there's no strict definition, but some of the things that I think of and some of the things that I hear from patients are that there are memory problems, so difficulty remembering things and forgetfulness, concentration difficulties, so difficulty focusing and maintaining attention. There can be thinking and thought processing issues, so difficulty with planning, organization, and problem solving, and also sometimes language difficulty, so trouble finding the right words or expressing your thoughts fully. Now, cognitive impairment is one of the most common diffuse manifestations of NPSLE. The prevalence is around 40%, though it can range anywhere from 20% to 80%, and that's depending on how we measure it. And we know that cognitive impairment negatively affects health-related quality of life. But despite this, cognitive impairment is one of the more poorly understood presentations, and therefore it makes it very difficult for us as rheumatologists to actually manage this in clinic. And furthermore, assessing cognitive impairment in lupus can be very challenging. Currently, there are tons of objective measures for how to actually measure whether or not cognitive impairment is present. I have these listed on the left here. So we have things like the MoCA or the MMSE, and then there's also the American College of Rheumatology Lupus Neurocognitive Battery. And that's currently the gold standard for objectively measuring whether or not cognitive impairment is present. But it's a 1 to 2 hour test. It's actually multiple tests, and it looks to identify deficits in multiple cognitive domains. So it's very cumbersome, and it's not something that can just be done for every patient at every visit. And the other thing too is that objective measures do not always measure the patient-reported symptoms of cognitive impairment or brain fog. And we know that factors such as depression, anxiety, fatigue, and chronic pain directly contribute to the subjective symptoms of cognitive impairment. And so oftentimes in clinic, and this comes to my next research question, is there a tool, we often think, is there a tool to help us measure subjective cognitive impairment or brain fog without doing a very long battery of neuropsychological tests? And so there is a test called the Perceived Deficits Questionnaire 20, or the PDQ 20. And it's a 20-question self-reported survey that we can give to patients, and it looks at subjective difficulties in 4 different domains. So it looks at retrospective memory, prospective memory, attention, and organization. And it was actually originally developed for assessing subjective cognitive impairment in patients with multiple sclerosis, which is an autoimmune disease of the central nervous system. But it has also been adopted in conditions like lupus, and there's also a PDQ 20 for depression, and then it has been adopted for post-COVID-19 syndromes or long COVID as well. However, although it has been used in lupus, it has not been studied in detail. Now, the way that it works is that higher scores on this test mean that there's more subjective symptoms of cognitive impairment or more brain fog. However, higher scores do not always mean more objective cognitive impairment. So, or, more impairment measured by this gold standard, the ACR neurocognitive battery. But we do know that higher scores on the PDQ-20 have been associated with higher scores in certain tests for anxiety, depression, and fatigue. So one of my research projects when I was doing my fellowship in Toronto with Dr. Touma at the Toronto Western Hospital was looking at subjective cognitive impairment and how can we measure it using the PDQ-20. So first off, we looked at symptoms of cognitive impairment. So what types of subjective CI symptoms do patients with SLE have, and which domains are more affected in patients with lupus? And then we looked at objective CI versus subjective CI, and we aim to characterize patient responses to the PDQ-20 to results of the ACR neurocognitive battery and whether or not there was a link or if those results matched. And we looked at individual questions from each set of tests, as well as compared the different domains that each test tests for. And then the last thing we wanted to look at was the reliability. So is the PDQ-20 a helpful test to detect cognitive impairment in lupus? And do we think it'll be helpful in research or in clinical practice going forward? So some details about the study, and it's still ongoing, but hopefully will be submitted for publication soon. We had about 230 patients with lupus who completed the study, and it was part of a larger study on cognitive impairment in lupus at the Toronto Western Hospital. Patients in this part of the study completed both the PDQ-20 as well as the ACR neurocognitive battery. So completing tests for both subjective cognitive impairment as well as objective cognitive impairment. And then we analyzed results from both of these assessments and compared the two. Now, just looking at the long list, so there's 20 questions in the PDQ-20. You can see that they're divided into 4 different domains like we discussed earlier. And if I go forward, this is essentially what the participants would fill out. So this is just a sample, but you can see here, for instance, number 9, during the past week, how often did you have trouble concentrating on things like watching a television program or reading a book? So that's asking about subjective symptoms of attention. And here you can see that 0 is a low score and obviously 4 is a higher score. So the higher the score across all these 20 questions, the more subjective symptoms there are of cognitive impairment. And that's the same thing there. And then here, I won't go into this in great detail, but you can see this is the actual objective testing that we do to determine whether or not someone objectively does have cognitive impairment or not. And so this battery of tests has 6 different domains, and you can see them listed out here. And there are 19 total tests. And so you can imagine this is why it takes about 2 hours to actually complete. So the first thing that I wanted to show was when we actually had patients fill out the PDQ-20, what kinds of questions were answered almost always or often regarding the different questions. So here you can see, I mean, it's a very colorful slide, but the questions that had the most answering these almost often or, sorry, often, almost always or often were these questions. So having trouble holding phone numbers in your head, finding your mind wandering, having difficulty remembering the names of people, and having trouble getting started on tasks. There we go. And then we looked at the average score among these 230 patients across each of these 20 questions. And the scores that, or the questions that had the highest scores were those that had looked at the mind wandering, difficulty remembering the names of people, losing your train of thought, which that's apparently happening to me right now, and forgetting what you came into the room for. In contrast, the lowest scores were things like forgetting to do things like turning off the stove or turning on the alarm clock or missing appointments and meetings. So it seems like patients are able to still function, but the quality of life may be lower because of some of these deficiencies. And then we looked at the domains that the PDQ-20 tests for. So again, remember that's attention, concentration, both retrospective and prospective memory, and planning and organization. And it seemed that the total scores were higher in the attention and concentration domains, as well as the planning and organization domains, though the retrospective and prospective memory domains were less affected. And then we looked at, do these PDQ-20 scores actually help us differentiate between patients with objective cognitive impairment as measured by that long test, the ACR neurocognitive battery, and those patients that actually did not have cognitive impairment based on those objective tests. And we did find that there were slightly higher scores on the PDQ-20 in those patients that did objectively have CI. But both groups really did have high scores across all questions, and there were similar fluctuations in the scores across the 20 items. So it did not seem that it was a reliable test to distinguish fully between cognitive impairment and normal cognition. Now, this is a very busy heat map graph, but essentially what we wanted to do was look at the correlation between whether or not a certain question, so the 20 questions on the bottom, the PDQ-20, whether certain questions correlated with certain tests of the ACR neurocognitive battery. Instead of seeing certain tests linking up with certain questions, we actually saw that certain questions on the PDQ-20 just corresponded quite uniformly across all of the ACR neurocognitive battery tests. So again, things like trouble holding phone numbers in your head, trouble concentrating, interestingly missing appointments and meetings, or difficulty planning, those questions seemed to correlate with worse performance on the neurocognitive battery. But then when we actually looked at the different domains that are being tested by these tests, you can see on the left, on the y-axis, the ACR neurocognitive battery domains, the 6 domains, and then the 4 domains on the bottom, as well as the total score. And there was actually no correlation between the two tests, which has been seen in the literature before, but this just further shows that these tests may not be actually testing the same thing. So then that begs the question, well, how should we be using this PDQ-20 test? So we know that it's a patient-centered method. And the good thing about it is that PROs, or patient-reported outcomes, acknowledge the lived experiences of patients. And this also recognizes that cognitive dysfunction in lupus is likely deeply intertwined with other systemic and emotional disease manifestations. And tools like the PDQ-20, or subjective tools, we know that they don't frequently associated with objective measures, and in this case, objective cognitive impairment measures. But what this may offer is clinicians a valuable tool for flagging patients for further assessment or for early intervention. And it may be that the PDQ-20 is not a global measure of cognition, but it only focuses on specific cognitive domains. And the relationship between these subjective symptoms and objective cognitive impairment is likely more complex than we understand. And we also know, which we did not do this analysis in this study, but we also do suspect that PDQ-20 scores are affected by things like depression, anxiety, fatigue, and chronic pain. And so perhaps the PDQ-20, if there are high scores, this may alert the physician to screen for other symptoms that can be associated with subjective cognitive impairment. So depression, anxiety, etc. So I wanted to go back to our make-believe patient, Sarah. So Sarah speaks with her rheumatologist on advice from her family doctor, and she is actually screened for anxiety with a test called the GAD-7 and screened for depression with a test called the PHQ-9. And screening actually suggests that she does have symptoms of depression. And so she's referred to mental health and cognitive support services, and she's set up with a psychologist. And after several months of performing something called cognitive behavioral therapy, which is a type of counseling, she starts to feel better. At this point, she doesn't feel like she needs medications, but she is open to it in the future if things aren't improving further. And over time, she develops coping strategies, and this helps to improve her quality of life. For instance, she takes 2 days a week for herself to partake in a yoga class. And then she also has a close friend who she speaks with weekly about how she's feeling. So, this may be an ideal story. Um, I would say that I'm sure that not every patient has this, I guess, situation if they were to bring things up with their rheumatologist or with their family physician. However, I would say that support in any means can make a difference. And I think you'd be surprised that if you spoke with your rheumatologist about symptoms of anxiety, depression, or concerns about mental health, that they would actually be quite open. And maybe that is the push that the rheumatologist needs to be able to start considering these things in their practice and perhaps addressing these types of symptoms more frequently with other patients. And so the story might not always be linear, but I do truly think that support, whether it's from your rheumatologist, your family physician, friends, family, can definitely make a difference. So I wanted to just talk about some quick supports available in Ontario, although I'm in Alberta right now. So this list is not exhaustive, but here are some potential resources. So obviously, Lupus Ontario, or if you're in another province, another provincial lupus organization. Lupus Canada has some good resources. The Canadian Mental Health Association, if you go to their website, does have some links and options for addressing and finding mental health services on your own. And then obviously, like I said, speaking to your rheumatologist and primary care physician is sometimes the first step. And I know that that can be challenging, and you know, people do still feel, as we saw in one of the studies, that there is stigma surrounding mental health. But I think that things are changing rapidly, and as things are progressing, physicians and patients can hopefully become more comfortable discussing these topics. I will also put this up. This is the Center for Addiction and Mental Health, or CAMH, and they actually have this program called the Ontario Structured Psychotherapy Program, and it offers free services. It's publicly funded, and it's short-term cognitive behavioral therapy, or CBT, with a psychotherapist. And CBT is one of the methods, aside from other types of therapy or medications, that has been proven effective for patients with anxiety and depression. And then I'll also plug Lupus Ontario again. They had this prior webinar from January of this year looking at navigating mental health and lupus. And so obviously I went through some of my research and what we're doing in terms of going forward with more research and clinical care. But this does provide some support and navigation for mental health care. All right, it's been a long day for me. It's only, what is it, just almost 6 o'clock for me here in Edmonton, but it's later for all of you. I wanted to say thank you very much to Lupus Ontario. Obviously, I was funded by the Geoff Carr Fellowship for my work in Toronto. And I wanted to say thank you to the team at UHN, the Schrader Arthritis Institute. So Dr. Touma, Dr. Gladman, and Dr. Whittle Garcia, and the whole research team. And then also thank you to my colleagues at the University of Alberta, who I'm working with and I will hopefully continue to do research in this area going forward. So I would I think we have some time for questions. I would love to take any questions, and I may not be able to answer all of them. But thank you so much for listening and participating.
Thank you so much, Dr. Justin Smith. That was a wonderful presentation. I personally learned a lot, especially when it was the PDP, the 20 there, as well as the psychosocial models. So yeah, a lot of wonderful stuff. Everyone feel free to go into the chat and write a question you may have, or you could also use the Q&A function, and I'll be sure to filter anything out. Yeah, so thanks again, Dr. Justin Smith, for joining us. And again, what a wonderful presentation. The first question is, can CI meds affect lupus meds?
So I'm not exactly sure what you mean by that, Anne. Oh, I see. Like, do they interact together? Is that what you mean? I would say, right. So I would say on the flip, so no, I don't think so. Obviously, there are lots of different medications for depression and anxiety, and then tons of different lupus medications. Generally, there should be no interactions. Um, Hydroxychloroquine or Plaquenil can very, very rarely lead to something called QTc prolongation, which is just an elongation on an ECG or the heart rhythm strip. Some anxiety or depression medications can also do that, but you know, in my experience, it's not clinically significant. And so I don't think that we should really be limiting the medications we use just based on that. So overall, I don't think that you'd have to be worried about that.
Another question in the chat. Are there ways that a patient can receive counseling referred by the doctor, i.e. from lupus clinic, and can be covered by OHIP rather than CMHA?
Right. So that's challenging. Um, so from my perspective, if we as rheumatologists refer to mental health services, if we refer to a psychiatrist, then it would be covered by OHIP. And some psychiatrists do perform psychotherapy, as well as provide prescription medications if that's the case. And so in that case, yes, it would be covered by OHIP or your insurance. Um, Unfortunately, in my experience or in my understanding, most other either psychologists or therapists probably, even if we suggested it or referred, it's outside of, um, I guess, the physician's territory, so it's probably not going to be covered by OHIP. And so at that point, it depends on private insurance. Um, and then that's one of the challenges is that I think that therapy counseling is beneficial for so many reasons, whether you have lupus or you have other things going on in your life. Um, yeah, exactly. So that's one of the challenges is that psychologists are costly, social workers are costly, and unfortunately, private insurance doesn't cover this. So this is one area I think that we need to do better. Um, and so going forward, I think that discussions regarding into even though physicians based on our study did not think that integrated services within the clinic would be helpful. I think for that very reason, because not all patients have access to it, that there should be a more formalized pipeline. And so that's one of the things I want to do, at least in my clinic at the U of A, is try to establish a quality improvement initiative to have a better pipeline or a better referral process so that it's less cumbersome from my end, but also so that patients have better access and hopefully better affordability. So unfortunately, yeah, that is one of the major issues we have right now. Yeah, that's a great idea. some sort of like pooled funding. And I wonder, um, I mean, that's the problem. It's very difficult to get money to deal with a lot of things. Um, from a research perspective, at some point, I'm hoping that perhaps getting a grant in this area could at least, um, you know, fund that type of thing from a research perspective. Then, of course, it has to be applied to the broader public. So that's a great idea. I think that's something to continue looking at going forward.
I have a quick question. You spoke a lot about the barriers on the patient side of things. How can healthcare providers foster more open communication about mental health and like cognitive health with their patients?
Right. So something that I started doing as part of my just day-to-day practice, and I'm not always the best at it, I have to admit, but as something or as a patient, sorry, as a physician who sees a lot of patients with lupus, and a lot of patients probably recognize this, we have this thing called the review of systems. So I ask a detailed list of types of symptoms. So, any new rashes? How are your joints? Um, any chest pain, any breathing difficulties. I've started in, depending on what's going on, in a lot of patients asking, how is your mood? Are you having any symptoms of anxiety? Um, Now, I have to admit, if someone is very sick from active lupus, I do care about those things, but sometimes the other symptoms take precedence. And obviously, we want to make sure that the lupus is well controlled. But I have been trying to add that in as part of my review of systems. And the other thing too is that hopefully what I want to implement in my clinic is having standardized screening. So we have these tests that are already very well used and very well studied, but having very short, the GAD-7 and the PHQ-9, they're exactly what they say. 7 questions in the GAD-7, 9 questions in the PHQ-9, and having that just done before I see the patient. And then if there are concerns, then we can address them right then and there. Um, I would say that I'm not attuned to treating depression and anxiety, just like a lot of the physicians in the study. I'm not comfortable necessarily treating long term with these medications. I learned about these medications in medical school. Have I used them since? Not really. But at least it starts to open up that conversation. And then if there is a pipeline to access these types of treatments after that, then I think that can directly affect patient care.
Thank you. And is there any other questions anyone in the audience may have before we wrap things up?
Oh, so I'll I'll read it out because it's
Yeah,
pat
just
on
a
the back
comment.
for me. So not a question, but just wanted to say I'm sad that you are no longer working with patients at UHN, one of the best fellows I've received care from. All the best to you in Alberta. Thank you so much, Corinne. Um, yes, I have to say I was only in Toronto for 1 year or a little bit over a year, but I had an amazing time with Dr. Touma and Dr. Gladman and Dr. Whittle Garcia in their clinics, and seeing so many inspirational patients, and how severe lupus can be, and how we can actually work with the patients to get through it and not only address the concerns regarding active lupus but other things, um, was truly inspiring. And I think that's the most important thing I gained from the fellowship. Yes, I got to learn a lot about lupus and I got to learn or start a lot of research projects, but um, you know, that inspired me to keep going. And I'll have my lupus clinic here in Edmonton, and hopefully all of us across Canada can continue to do this work together to progress things going forward. So thank you so much.
Great, thank you. Yeah, and with that, I'll just like to, oh, there's one more that came in before we conclude.
Okay. Yeah, Sharon is saying, I like the idea of asking the PHQ-9 and GAD-7 question um, at the beginning of the session, and she's a therapist. So yes, I totally agree. And actually, I find so I'm an adult rheumatologist, but pediatric rheumatologists have started doing this already in their clinics. And of course, they're always ahead of the game. So I think that we need to take a note from them and start doing that. So I totally agree.
Great. And yeah, I just want to echo what Sharon said in the chat. Thank you so much for your research and your wonderful presentation and for your time tonight. And thank you for everyone for joining us this evening. We appreciate your time and engagement in today's webinar. To stay up to date with future events and resources, be sure to visit our website at www.lupusontario.org and follow us on our social media. If you join late, don't worry. This webinar will be recorded and posted on our YouTube channel in the upcoming days. So wishing everyone a wonderful evening, and we hope to see you all again sometime soon. Thank you so much.